Good evening, everybody. Welcome to our IBRA, International Bone Research Association webinar of the lower extremities, foot and ankle. We have today the chance to have a very nice battle webinar in the area of the bunion surgery and bunion treatment. And with me are together Jim Carmichael. Jim Carmichael, he's from the NHS in UK, working in Peterborough and Stamford, a very experienced foot and ankle surgeon, as well as Dr. Christian Plaass. He's also a very experienced surgeon working in the Diakovere Hospital in Hanover, Germany. So the setup will be this way, that we will hear an introduction presentation by each of the one presenters. Then we will have a discussion and also cases to discuss. Yes, I want to get a little bit the interactivity of our people listen to this webinar. Here a question, a poll question number 1. So please read the question and vote. So what is the proportion of bunion deformity or hallux valgus do you actually treat with a TMT1 fusion? So how often do you perform a TMT1 fusion in your bunion cases? Please vote. 10%, 30%, 50%, 60%, or more than 90%. So the results are here. You can see them. The majority, they say under 30% or under 10%, they use a TMT1 fusion to treat the bunions. That means 70 to 90% are using a joint preserving solution. So this is a good start for Jim. So Jim, you have full wind to support your theory. So let's start. Okay, Christian, so you will have a very bad situation because you have to convince all the people that the fusion is better than an osteotomy.
Okay, I try so, and I hope afterwards the poll will look a little bit different. So first we wanted to start with a short story about the Hallux valgus etiology and how our understanding is evolving at the moment. When we look at the past, we looked at the Hallux valgus as a horizontal pathology with a medial deviation of the first metatarsal, lateral drift of the proximal phalanx, a loss of abductor function, and a decentration of the flexors and extensors, leading to a circulus vitiosus. We used a classification just focusing on the horizontal way, with a mild deformity defined as a hallux valgus angle between 21 to 30 degrees, moderate 31 to 40, or severe forms with more than 40 degrees of deformity, which also led our therapy with mild forms to treat by distal osteotomy and more severe forms with proximal osteotomy or TMT1 arthrodesis. But this classification completely ignored other factors which also showed to be important for the development of hallux valgus, for example, like the DMMAA, which we looked at for years and made us make double osteotomies and so on to treat hallux valgus to correct this angle. Perhaps there are some things we overlooked, and this led to a new thinking of hallux valgus. When we stand back and look what a hallux valgus really is, you see it is, of course, a big toe valgus. It is a metatarsus primus varus, but it also is a pronation of the toe, as you see here. With evolving imaging techniques, we also can look at the form of the hallux valgus, and what we see in our textbooks until now is mostly what you see here as 2 shown up here as number 2, and but when you look on the weight-bearing CTs, you see it's only true in about 10% of the cases. When you look down here, you find that about 90% of the cases of hallux valgus have a pronation of the metatarsal with or without sesamoid subluxation. You see the effect here too for the DMAA. You see on the left side the pronation, the form, and on the right side the derotated form. As you see here on the slide, you see that the rotation and the DMAA is a direct function of the rotation of the metatarsal. And when you see, as you see here on the right X-rays, when you have the hallux valgus position, you have the sesamoids decentered, and when you derotate it, as you see here on the right side, you have them repositioned, subluxed, and then you do the derotation and see them repositioned. And the same is with the round sign, which is here, as you see here, the condyle of the metatarsal, which is also predictive for hallux valgus recurrence, which is gone when you derotate the first ray. Now, what is the basis of this rotational instability? This is phylogenetic. When you look on our foot, it's just 4 million years old, which is nothing when you look at the evolution. And it changed from a grasping to a standing. That means from a mobile to a stable extremity. And you also see this in the anatomy. You see on the down left, you see the foot of a gorilla, and on the right side, you see the foot of a human, and you see the change of the first ray, which is adducted and derotated. And when you look on the gorilla foot, I think all of you see some similarity to the hallux valgus. Here you also see an anatomic equivalent to it. You have different forms of the TMT1 joint, which have different risks to develop an hallux valgus. Next. So our actual understanding of the developing hallux valgus etiology is that the hallux valgus develops in the TMT1 joint due to abduction, elevation, and rotation. But the question, and this is what we want to discuss here, is if we really have to treat it always at the TMT1 joint. And this is where we have the next poll for you. And the question here is if you have ever looked at a rotational deformity in your patients till now. Okay, that many of you looked at it clinically. And some also used sesamoid views or DP radiographs routinely to analyze the rotation. I think this is an interesting finding that already is in your mind that you care about it. And now I think I would give over to Jim to talk about his view about how to treat hallux valgus.
Okay, when we look at the hallux valgus deformity and we look at our patients, what we're trying to achieve for them, which is essentially a pain-free foot, we need to first really understand what we're dealing with, where the pain is coming from. And this is a very common presentation that we see. Our patients will complain of pain both from the medial eminence and then the effects that the instability that the deformity has created on the foot will go on to cause within the patient. And that's usually manifested either by transfer metatarsalgia or as a sequelae of that, and the overload goes through the lesser metatarsals, the secondary degenerative change that will occur in the foot. What we're trying to avoid is the sequelae of the correction procedure. So we don't want to have a recurrent deformity if possible. We want whatever correction we achieve to be long-lasting, and we want to avoid either the painful stiffness of arthrofibrosis in the joint as a result of that, or the altered mechanics effects such as transfer metatarsalgia that can occur if you've done an incorrect correction. Equally, you want to be able to deal with the sequelae that happen. We know that a large proportion of people in hallux valgus corrections will have degenerative change in the foot at the time of the index procedure, and we want to be in a situation that we can deal with degenerative change, particularly in the first MTP joint, as it arises later. So the ideal procedure will not just correct the cause of the symptoms, but it will hopefully minimize the risk of the sequelae that we're having. And increasingly, we're starting to realize that it's important that we maintain as much normal foot mechanics as possible. Finally, we need the procedure to be reproducible and long-lasting. As Christian's been saying, increasingly, I think more and more foot and ankle surgeons are realizing that the fundamental cause of the hallux valgus is TMT joint instability. Obviously, therefore, if you're dealing with TMT joint instability as the cause of your pathology, it makes sense to deal with that. And therefore, surely you need to fuse the TMT joint. But actually, it may well be possible to stabilize the TMT joint without fusion. And the first ray stability is the combination of the bony, ligamentous, and dynamic aspects that are involved. So if we look at the normal situation here on the left-hand side, we have the stable first ray, and you can see not just the bony blocks make up for a relatively stable configuration. I haven't put the ligaments on, but the tendons themselves exist forces across all the joints that exist in fundamental balance. As soon as you start to develop a deviated first ray and a metatarsus varus, you destabilize that intrinsic balance within the tendons. If you can correct that alignment, however, you can restore that balance. And even though fundamentally the bone in the middle is remaining S-shaped, you can restore the stability of the first ray just by replacing the metatarsal head back over the sesamoids. This has been shown. There's been 2 studies particularly that have looked at the effect of correcting the hallux valgus and the metatarsal alignment on the stability of the first TMT joint, both of which have demonstrated significant improvements in the TMT stability, even measured as detailed as with a micrometer, follow up out to 2 or more years, and it's been maintained throughout that period. So if you look at the things that certainly for my practice make me look at the osteotomy as the workhorse rather than the exception, and the Lapidus as being the ones I reserve for certain cases, the principles really are that the TMT joint in the normal foot is a mobile structure. And we don't really know what the long-term sequelae of a fusion of a TMT joint are. We know that in other areas of the foot, if you arthrodese a certain joint, you do create knock-on effects to the other areas. We don't know what the incidence of navicular cuneiform joint osteoarthritis is, of intercuneiform instability or symptomatic arthritis there. And we don't know what the implications of combining a metatarsophalangeal joint arthrodesis on top of a Lapidus arthrodesis in terms of likely success rate and outcomes for the patient are. Those studies just simply do not exist as yet. Equally, is that there's a problem that if you stabilize aggressively the midfoot through a Lapidus arthrodesis, you are probably more likely, in my opinion, to develop the postoperative complication of sesamoiditis. Arthrodesis is fundamentally a destructive procedure. And there's no going back once you've started that. There are numerous studies that report shorter recovery with an osteotomy, and certainly return to play in some athletic studies have shown return to play as soon as 8 weeks after an osteotomy. I would argue that the osteotomy can be a less invasive procedure that the patients prefer. And in my hands, certainly, I think a correction or a revision of an osteotomy, either to an arthrodesis or a further osteotomy on the very rare occasions that's possible, is less challenging. Certainly, the concept that the Lapidus procedure is more prone to needing further surgeries is supported in some papers. In this particular paper, they looked at a very large retrospective case series of 640 cases. 340 had a Lapidus. And the reoperation rate following the Lapidus procedures was significantly higher. Well, no, I say significantly, sorry. It was higher than following the chevron osteotomies. It didn't reach statistical significance, but there did seem to be a positive correlation with removal of metalwork on non-union by the Lapidus procedures. The other thing that I would like to just put out there initially is we know increasingly that the patient experience from the osteotomy procedures or from the corrective procedures often is not directly correlated with the radiological features that we measure. We've all experienced the procedure where you've done the absolutely perfect radiological hallux valgus correction and the patient is symptomatic. And I can certainly as well think of at least 1 or 2 cases where radiologically I've been very unhappy with my result, but the patients walked out of my clinic room extremely happy at 3 months and has yet to return. So that does raise the possibility that is actually overall foot function and therefore maintenance of a mobile midfoot perhaps more important than absolute reliance on maintenance of a complete correction. Looking at the studies that have looked at the athletic population, this is a very recent paper, and it's a review of a very heterogeneous group of studies, so it's not really a true meta-analysis, but they have found that from the papers that they were able to review, there was a significantly lower ability to return to activity following a Lapidus procedure, or athletic activity following a Lapidus procedure, than there was in the studies that looked at osteotomy procedures. And they also found an underlying lower rate of satisfaction following Lapidus when compared to osteotomy. And I think this population group is quite important because although they're a very difficult population group to deal with, or challenging population group to deal with, they have a very low tolerance for abnormality in their foot. So the implication that they are able to get back to sport better does again support the osteotomy as a more tolerated procedure. So what is the scarf and Aiken osteotomy? Fundamentally, it's an evolution of the chevron designed to both increase the stability of the bony cuts and also avoid the plantar blood supply into the metatarsal head and thus try and reduce the incidence of avascular necrosis. There are basically three components. There's the lateral release, the long scarf cut that that allows you to laterally displace the metatarsal, and the Aiken procedure can be added in as needed to correct the interphalangeus. Initial descriptions of the study looked at a very vertical orientation of the cuts and a longitudinal cut straight up the middle of the metatarsal. And that, I think, was responsible for some of the early reports of poor outcomes, such as the paper by Coetzee et al., that demonstrated significant incidence of guttering and things following the procedure. Now, following the modified procedure, they have modified their opinions to say that it is now a very powerful and reliable procedure. Fundamentally, I think the advantages of the scarf and Aiken are it allows a very powerful correction. The length of the cut not only promotes bone healing, but it allows for a very stable osteotomy secured with minimal fixation. This allows early weight bearing, and that improves your patient experience and outcome. It is possible to correct it in multiple planes. We know this. You not only are displacing the metatarsal head laterally, you can accommodate early degenerative change in the metatarsophalangeal joint by slightly decompressing the metatarsal as you move it across, and you can alter your horizontal limb to at the same time plantar flex the osteotomy, maintaining the first metatarsal head loading and in theory reducing your incidence of transfer metatarsalgia. It stabilizes the TMT joint without sacrificing the joint. And by maintaining that midfoot movement, I think it allows for more forgiving MTP joint arthrodesis should you develop ongoing arthrofibrosis or MTP joint arthrosis later. So what are my indications for the scarf and Aiken? Usually, most hallux valgus with an intermetatarsal angle under 20 degrees, my go-to procedure will be the scarf and Aiken. Obviously, there's the considerations around the fact that the hallux valgus must be symptomatic, and certainly in the NHS, this is becoming increasingly important. There needs to be as little degenerative change as possible. And I mean that both in the first MTP joint and in the TMT joint. I will allow MTP joint degenerative change by accommodating some of the cuts a little bit, although I tend to err towards an MTP joint fusion as the procedure of choice if there is symptomatic degenerative change at the MTP. If there's TMT joint arthrosis in conjunction with a wider IMA, go-to procedure again becomes a Lapidus. I start getting a bit worried about the osteotomy procedures if the Meary's line is disrupted, either evidenced through a sag in the midfoot or plantar gapping at the TMT joint, or evidence of significant subluxation of the TMT joint on the AP film. And I'm increasingly, particularly after working on this study, being aware of the round stone as a means of identifying significant rotation. I will look more carefully when the IMA is above 18 degrees. And I will look at it with this test that Meyerson described in his book, Reconstructive Foot and Ankle Surgery. Essentially, what he does, there's a missing X-ray on the talk, I'm afraid, sorry, but if you've got an X-ray with a very wide intermetatarsal angle, repeat the X-ray with having strapped the forefoot. Now, you'll have to take my word for this, unfortunately, but the previous picture had an intermetatarsal angle of about 23 degrees, and it's been corrected simply by squeezing the forefoot together and putting strapping around it. And in that situation, I will go to a Lapidus procedure to maintain that correction. My technique for the scarf and Aiken osteotomy, I do believe in the separate lateral incision for the lateral release, partly because when I first started, the majority of recurrences that I was seeing coming from other surgeons for review were when the scarf had been done through a single incision. So I find that the ability to do the lateral release through the separate incision, allowing for sequential release of the suspensory ligament, the insertional band, the adductor tendon, the lateral collateral ligament, until you can get sufficient correction to slightly overcorrect the hallux on the metatarsal head, is a very useful part of the procedure. I will resect the medial eminence, but I'll try and maintain not just the sesamoid articulation, but also a small lateral buttress to try and prevent an overcorrection. I do use the modified scarf cuts adjusted as necessary to account for pathology. To a limited degree, you can accommodate for a DMAA, but it's important to realize that this is a fudge. And by that, what I mean, I agree with the Christian that the DMAA is a rotational phenomenon. If you're using maestro cuts to try and adjust for the DMAA, you're fudging the issue and trying just to make your x-ray look better. I've recently started to try and preserve the dorsal capsule, and this is an acknowledgement of the arthrodesis element. And my theory in doing this is that if we can minimize the amount of capsular stripping and disruption around the joint, you may minimize the arthrofibrosis. Early results seem to be promising, but I've got no data to back that up. And finally, there's the element of the medial reef, which in my hands, I try and minimize. I'm much happier if I can get as much correction and maintain the correction with as little soft tissue tension as possible, again, to try and reduce the arthrofibrosis. But on occasion, you do have to use a fairly aggressive reef. My rehabilitation protocol, immediately full weight bearing, immediately in a flat postoperative shoe. I don't like the heel weight bearing shoes. Patients don't like them, and they find that it throws the hip and back out. Flat postoperative shoes have recently been shown in another study to be perfectly adequate. I use an alignment spin if I'm in the majority of cases between weeks 2 to 4, but if I'm worried about an overcorrection, I don't use one. And I start range of motion exercises aggressively from week 2 with formal physiotherapy from week 6. The results, when you look at the overall performance of the scarf and Aiken, are actually very good. There's a lot of studies about this. This osteotomy has been around for a long time, so I'm not going to go through the detailed literature, but there was this very good current concepts review in Foot and Ankle International 2-3 years ago, which did review the studies. They acknowledged Kutzi's paper early on where he had poor results, but on the basis of the results they identified, they gave the scarf and Aiken a grade B recommendation for the correction of Hallux Valgus, even up to wider angles. I have to admit, in the evidence of transparency, that they gave the same level of recommendation for Lapidus. Speaking of which, over to you, Christian.
Thank you, Jim. Christian, you have heard the osteotomies on the metatarsal 1 and on the phalanx are quite powerful and save a joint. Do you agree with that? I think Jim is providing really significant evidence, so I hope you can protect the Lapidus as good as he did. Thank you.
So, yes, Jim, thank you for your nice presentation. I think I can give some ideas against it. First, we are all orthopedic surgeons, and one of our laws we believe in is the correction in the center of rotation and angulation. And when you look at the hallux valgus deformity and all the different kind of osteotomies which have been described, you see that they all ignore this principle. You have always a zigzag deformity of the first metatarsal, and this principle is ignored. And what you also did not show us is that the long-term outcomes, when you look on the 10 to 15 years outcomes, is not as good as the short-term outcomes. When you look, for example, there are different studies out there. I just took this one because it shows chevron and scarf osteotomies. They have a relapse of hallux valgus deformity in up to 78% of the cases. Now you can argue that this is just radiographic finding, but this is not true, because when you look, for example, on the results of the Mitchell osteotomy, you also find in 1/3 of the patients clinical poor results with metatarsalgia, recurrence, or simply as non-good judged results. This also goes for the basal closing wedge osteotomies. You can find these results for basal opening wedge osteotomies also here with 64% radiological recurrence rates. So my arguments for the TMT1 fusion are that the TMT1 joint is the origin of the deformity. The TMT1 joint is a non-essential joint of the foot. As I showed at the beginning, we got it from our ancestors, but nowadays mobility means deformity. We can do a three-dimensional correction in the TMT1 joint. We can do rotation, we can adduct, abduct the metatarsal. And today it is a safe and reliable procedures. And many of the complications which have been discussed years ago are nowadays no topic anymore, all because we got better implants. Of course, we also have to discuss what really means the Lapidus procedure, because there are many different theories or thinkings what it is, the Lapidus procedures. First, I want to give some background about Paul Lapidus, because I think there's really a misunderstanding with his name. Because it was not him who identified the TMT1 joint as an origin of Hallux Valgus pathology, but, and this is something he states in every paper he wrote, that there have been many people before him which also discussed about the TMT1 joint and also showed this as anthropologists, that this is a cause of Hallux Valgus. Also, the TMT1 fusion to treat the Hallux valgus was not first described by Lapidus, but by Albrecht in 1911. And something that is also not often stated is this: Paul Lapidus did not treat all patients with Hallux valgus with a TMT1 fusion, and this is something also we can discuss later on, because he said it's a useful procedure in properly selected cases and not always indicated. His indications were an intermetatarsal angle over 15 degrees. So this is about what I think and what we do. And this is interesting because this is contrary to what Jim told us. He also did in the 1930s this bandage test, but he said when you have a fixed varus position of the metatarsal, then you should do the Lapidus procedure. So this is completely contrary to what Jim just told us. Another myth is that Paul Lapidus recommended us to do an intercuneiform or intermetatarsal fusion always. He did that at the beginning, but in his last papers, he changed his thinking about this. And as you see here, he said, today our indication for these procedures are less frequent than when it was first devised. So the understanding of a classic Lapidus with an intermetatarsal fusion is not completely right. Another thing which is often wrong stated is that Paul Lapidus removed a wedge from the TMT1 joint, and I come to this later on because this is wrong. What he did, he really only scarfed off the cartilage from the joint with chisels. And he also discussed, he never directly wrote about us, but he also discussed the internal rotation of the big toe, which has to be corrected with the repositioning. He never really wrote how he did the repositioning, but he did not remove bone, but he looked at the rotation. So to conclude, Paul Lapidus was really a smart guy, because he already discussed the orthogenetic development of the Hallux valgus. He also discussed the principle of Cora correction. He, if not directly, but indirectly described a very modern, I would say, reposition maneuver. He also discussed the bandage X-ray test. And what I skipped in this text is that he really cared about the soft tissue management. So what are our indications nowadays for the Lapidus procedure? It is the intermetatarsal angle over 14 to 16 degrees. It is a metatarsus adductus. It is an instability of the TMT1 joint. I think this is something we can discuss later on a lot about. It's a TMT2 and 3 arthritis with Hallux valgus. it is a rotational deformity, as you find with the subluxation of the sesamoids, round sign, and so on. And interesting for us, osteoporosis is a relative indication because we think our fixation of a TMT1 or the TMT1 joint is safer than a chevron or scarf osteotomy. Now, what is the most important step of all arthrodesis? It's always the positioning. And the classic technique, or I would not say the classic technique, but the technique which was, at least in Germany, done for 20, 30 years, was this wedge resection, as you see here on the graphs. We were taught to take out a wedge, but this also led to some kind of shortening. This shortening was tried to compensate by a plantarization, but this did not really solve the problem of transfer metatarsalgia, and then there was a lot of discussion about doing a vial and so on, and this was really a problem for the patients because this led to quite a lot unhappy patients. What we know do nowadays, and what we understood, is that we really have to avoid shortening of the first ray. I do it by saw, but perhaps chisels would be better. You do not have to resect a wedge. And as a tip, always look at the bone in the lateral capsule because this can hinder repositioning. And what you do then is, as shown here in the video, I freeze the TMT1 joint, I put in a Hohmann retractor, which is not shown here, and then by derotation of the big toe, I reposition the first metatarsal, as you see here. And when you look closely, you see the subluxation of the sesamoids is corrected. The round sign, which is the plantar condyle of the metatarsal, is gone, and you see a nice closure of the intermetatarsal space. Come on. Okay. What I do not do, but what others describe, is that you have a fixed angle you correct. So what you do is you measure preoperative the rotation of the metatarsal, but I think this is cumbersome. It is not always available, the techniques you need for this, and the question is still if this is reliable. Next, the intermetatarsal angle does not always correlate with the amount of rotation. So what I prefer is to use the congruency of the MTP1 joint to reposition the TMT1 joint. So what you see here on the upper video, you see how you can indirectly reposition the first ray by a rotation on the base of the metatarsal. This is what you can do when you have a defined angle of rotation. And what I prefer is that you use the joint congruency on the sesamoid complex to reposition the first ray. What you do then is a temporary fixation. You use a leg screw, and then I like the plantar plate. What are my arguments for the plantar plate? You have improved biomechanics, you have less nerve and vessel damage, you have less tendon irritation, as you see here, as we analyzed in a study on the plate positioning, and you have a better soft tissue coverage of the plate later on. Now, of course, as Jim said, the Lapidus procedure may be argued as invasive, but you see here there's also evolving techniques, and this is more or less a classical approach. And here you see in a picture from Michael Hoya from Stuttgart. This is his way to do the Lapidus procedure with a standard plantar plate. You see very small incisions, and he has very good results with this technique. So what we have to discuss about is this original Lapidus. This means this intermetatarsal stabilization. This has been associated in the literature with some complications. You have painful, this I have to add, intermetatarsal pseudarthrosis. You have the feeling of stiffness in the midfoot of these patients, not so much in isolated TMT1 fusions, but in the, let's call it original Lapidus. You have hardware failures like shown here with backing out. You have fractures. And you have cases where the vertical mobility is reduced, or as you can see on the right X-rays, here you find bony bridges between the first and the second metatarsal. As you see here on the X-ray series in the lower side, you see here a patient with a TMT1 fusion and a relapse of the hallux valgus, and this is one of the cases where you have patients with a intercuneiform instability. You see here the instability is not always only in the TMT1 joint, but can be more proximal. So what we recommend that you do after a fixation of your TMT1 arthrodesis, hoop test and look under X-ray if the intercuneiform space opens up, then we recommend to do an intermetatarsal or intercuneiform arthrodesis to fix it. What's the after treatment? Full weight bearing is, especially with modern implants, safe and possible. The pseudoarthrosis rate, especially with plate and screws, is about 1 to 2%, which is similar for all techniques. You also find a lot of publications with 0% pseudoarthrosis. And there's no significant difference between early and late weight bearing. Protection is generally recommended. Many people use boots, others use shoes. I think this is up to you. And an adaptation of your after treatment might be necessary for regional differences. So what we learned is that our patients preferred really a boot before a shoe because they have a subjective, more safer feeling, and they also prefer partial weight bearing because of the less swelling you have with it for sure. Okay, Lucas. The patient satisfaction, depending on the studies you look at, are normally about 90 to 100%. And as Jim showed us, that the return to sports rate is in some studies about 80 degrees. But when you look more closely at these studies, you will find that this is not always directly associated with the TMT1 fusion. And you have also other studies which show return to sports rates for in a non-athlete but a normal population of about 91 to 100%. And when you look at lifestyle studies, you find that for all operations, 15% of the patients have reduced sports rates afterwards. What I have to admit is that the return to sports rate, the return to sports time is up to 8 months in the studies. The midterm follow-up from radiological is very good. You have an IMRA increase of about 1 degree over 40 months. Interestingly enough, you have with a classical Lapidus, so with an intermetatarsal arthrodesis 0% increase of the IMA after 36 months, and with a modified Lapidus of 1.4 degrees after 10 years. So you see there's still some mobility intercuneiform left. So now I showed you my arguments for the TMT1 fusion, and there's the next poll. I think you can read it. So I tried to formulate some questions. What is wrong? The unstable TMT1 joint is the reason for hallux valgus in all cases. Some patients have dysplasia hallux valgus. Poor bone quality is a reason to go for Lapidus. Radiologic recurrence does not always correlate with symptoms. And I have to admit some of these questions are my personal opinion. So please vote now.
Won't let me vote, Christian. I'm not allowed to vote. I won't let me vote. I'm not allowed.
Yeah, no, you're not. And all the others. And they do. Okay. There's still some votes coming in. And some do not agree with my opinions. Okay, I think we can stop the vote here now. And of course, I have to admit that the first question is wrong. The unstable TMD1 joint is not always the reason for hallux valgus. This is something I really want to point out, because you also have patients, for example, juvenile hallux valgus, which sometimes really have a dysplasia of the first metatarsal, and this is something you also have to look for. Victor, I think now it's time for you to open up the discussion.
Very well done, both of you. So I'm totally between both fighters. So I personally don't want to put you on the one or the other side. I think. What do you think, Jim? Do you believe in the good results that Christian is presenting?
I have to say, actually, I've undergone a little bit of a revelation with the Lapidus recently, in that my training as a registrar involves almost no Lapidus cases whatsoever. And when I first started, I wasn't using particularly good techniques, and I was very unhappy with the results. Having said that, having gone to see Christian work in Hanover and Christina, looking at the plantar plate particularly, the results from the Lapidus do, I think, seem to be significantly better, and the instance of non-union and symptomatic hardware by using the modern techniques do seem to be significantly better, which I think means now that I'm looking for the more significant rotational instabilities more than I used to. I do think still that when it's possible to correct through joint preservation, to address one of Christian's comments earlier about the fundamental principles of orthopedics, I think actually preserving joints when possible is probably more likely to give you the better result. But I am no longer anywhere near as worried about doing a Lapidus procedure with the newer techniques than I used to be.
You are supporting him, you know, Jim.
I still think this, the osteotomy is the preferable option, but I'm just not so worried when I have to convert to Lapidus.
Excellent, excellent. You have to be hard, you know, like in Brexit, in politics. You have to
We're doing such a good job with that one.
So, Christian, I like your idea that you presented, you know, to stabilize the first ray and get a good, solid correction. But you are killing a joint, you know. How do you want to convince all these 70% of people that still believe that osteotomy is better than an arthrodesis?
Yeah, I think it's also for us, it was an evolution. I mean, it really has to do with the understanding of the pathology. If you do the Lapidus procedure as it has been done for years, with this wedge resection, with shortening, with ending up in an incongruency of the MTP joint, you really have these results you sometimes find in the literature, which are or maybe worse than the osteotomies. If you understand the pathology better and adapt your technique to it, our results changed really, and also for us it was an evolution. I mean, for me it was the same thinking 5 to 6 years ago than what Jim says now, and we also changed our thinking in the last 5 years when we improved the techniques. And now we get this really good results by derotation, by analyzing the hallux valgus right at the beginning.
I think one of the features that I see in some of the patients that does just sort of emphasize my idea where it's possible to keep the joint, is those patients where you have a radiologically good result with your Lapidus fusion. You haven't overplantarized it, your alignment is good, your correction is good, and they come back with sesamoid irritation and sesamoid pain because they have behind this correction a fairly rigid midfoot. And I think that's one of those examples where preserving the joint buys you some leeway in correction and buys you some perhaps better outcome from the patient functions, because you have left some room for adjustment and accommodation within the foot.
So, Christian, how much percentage of your cases are you doing TMT1 fusion, and how much percentage you are doing an osteotomy?
I think we do about 60%, yeah, 60 to 70% at TMT1 fusions. I think this also depends on the kind of patients you have. You know, we are a university hospital, less severe hallux valgus may be treated more in an outpatient setting by others. But as I said, we start about 14 degrees on any signs of instability of the TMT1 joint.
And you, Jim, how much?
Probably almost diametrically opposite. Probably about 75% osteotomy, 25% fusion, but that is an adjustment from, as Christian said, 5 years ago when I was probably 90% osteotomy, 10% fusion. So the percentage of fusions has grown, but I've maintained still probably 75% of the cases as osteotomy.
Okay, so both of you believe in the opposites techniques, right?
Yes.
Yes.
Okay, that's good. So I would say I brought to the audience to get, you know, questions. So please, if you are listening to us, write the questions in the chat, and I will try to bring it into discussion. And maybe we can start with a case. Christian, I have you have a case here ready, right?
Yes, I brought a case for Jim. I have here Lucas. Yes, I have here a 16-year-old female, quite grown up, as you see in the gross areas, and she has a typical hallux valgus pain. So what would be your solution here in this case, Jim?
She looks, if I had to do something, which I try not to at that age, but if I had to, I would go for osteotomy.
Okay, what kind of osteotomy?
Scarf and Aiken.
Scarf and Aiken, yeah. So something like this?
Yeah.
This is not perfectly technically, I agree. What would you say? What is the outcome? What do you think is good? What do you think is bad about this operation?
So the sesamoids still remain slightly subluxed. The shortening from memory looking at the previous X-ray didn't look too bad. Intermetatarsal angle correction is not terrible. She remains a little bit subluxed on the metatarsal head. I've seen worse.
Okay.
But so I know where this is going.
you know it, yeah. So this is a result 2 years later on. You see if you would measure it, you would see that the intermetatarsal angle not measured to the head, but measured on the shaft area had increased dramatically, and she has a relapse. Mm-hmm. You said what you didn't like was the sesamoid position. What do you think? What was the reason for that?
Looking at how it's gone on now and compared to the previous X-rays, I think there's a degree of rotation of that metatarsal head. And if you look at the initial X-rays, there was a fairly significant round sign, which I have to admit was something I didn't used to appreciate either.
Okay. And this is what we analyze. This on the upper right, you see the sesamoid view, and you also see the CT view, and you see here this significant pronation of the metatarsal 1. And what you also see, interestingly, is that the sesamoids are not subluxed. This is what we learned for years, that what you see on the DP X-rays is a subluxation of the sesamoid, and this is not true. What we see there is an rotational artifact. The sesamoid are quite in position, but due to the rotation, moved laterally, and this leads to the relapse. And this is an issue with it, because you said you have more options to go back when you don't do a fusion. This is not true, because you can't do the right derotational technique as you can do primarily, because you have not any longer this straight metatarsal, but you have something like a hockey stick after this osteotomy. And what you have to do then is, what we don't like so much, is this classical Lapidus arthrodesis with a wedge resection, or with at least some kind of wedge resection, and a double osteotomy to correct the DMAA and to shift the sesamoids back. And this is what you see here. This is much more invasive for me than if you had done primarily with an TMT1 fusion. And when you look on the next X-ray, this is the other side. We learned, yeah, we don't stay where we are. And this is the way we solved it on the other side with a primary TMT1 fusion. And you see here the good and stable results over years. We put in here a TMT intermetatarsal screw because of the findings we had on the other side with the opening up of the TMT1 joint. I don't know if it was necessary, but we did it here because of the development of the other side, and she is happy with this side.
Maybe, Jim, if we look at this case before, how do you want to correct 30 degrees of derotation on a scar?
I have to say, I think if I'd appreciated that degree of rotational abnormality, I don't think I'd have taken on a scarf on it. I think trying to correct that extent of rotational abnormality through a scarf osteotomy, I'm not entirely convinced that's possible. And that's where I think the importance of appreciating the round sign when you see it is something that I'm learning to be more aware of.
Yeah, and how do you document this during the examination in the outpatient clinic, you know, to avoid these pitfalls that just we saw in this case?
I think it's basically trying to be aware of it as a phenomenon. I think I think that case was quite exceptional for what was essentially a relatively mild to moderate intermetatarsal angle to show that extent of rotational abnormality in the forefoot after the corrective osteotomy. That's not something I've identified myself so far as a common feature. So I think being aware of it is something to look out for, and particularly in a 16-year-old where the hallux valgus is going to probably have arisen at least in part to a degree of hypermobility or joint laxity because of the age group of the presentation. I think awareness is the key, being aware that there are cases that osteotomy isn't always perfect for, and being aware that there are good options that are available for those situations. I wouldn't go as far as to say it should always be Lapidus, because I think, as I said in my talk, we don't know what the long-term sequelae of a midfoot arthrodesis are, and we don't know what 10, 15, 20 years down the line, having fused the TMT joint may mean to the navicular cuneiform joint, etc. So I think where possible, still maintaining the movement is preferable. But being aware of those situations where your chance of recurrence is significantly higher is an important feature.
Yes, and for you, Christian, you know, because I'm wondering, maybe this question comes, but typically comes, how do you document during the outpatient clinic the instability? Because if you read in the books, it's always the case that's a sagittal instability, but I never saw bunion deformity to dorsiflexion. I see only the primus varus or the abduction, situation of the metatarsal one.
Yeah, this is a good question, and this is directly the question to the arguments Jim rose with the studies from Coughlin about the stabilization of the sagittal mobility we see after osteotomies. I think when you look at it and think of it, what we see in the X-rays is, as you said, is the abduction and the horizontal mobility, which we cannot measure. And the vertical mobility, which we can measure, does not really matter for what we for our treatment decision. So at the moment, we have no good technical method to measure the horizontal or the instability of the TMT1 joint, in my opinion. We only have the clinical experience of the surgeon, which has to decide if this is unstable. We have indirect signs. We have, in severe cases, TMT2 and 3 arthritis or pain due to the overloading of the TMT2 and 3 joint. But in many cases, or we have patients with a subjective instability feeling of the medial column, but I think we do not have a good technical possibility to measure the TMT1 hypermobility yet.
Mm-hmm. One question that come in from many persons is what are the percentage of your classic or modified Lapidus arthrodesis? Christian.
we know each other, Victor, so this is something we do not completely agree in. We do about 8 to 10% of classical procedures because we are afraid of some complications. This would be one of my next cases. I could show you with a complication of the intermetatarsal fusion. So we only do it in patients where we have this instability, this intercuneiform instability during the operation. But I admit that it means that you might miss some patients which have a developing intercuneiform instability. We accept this this risk of recurrence in some patients to avoid this complication of this procedure.
Okay, so Jim, maybe you start your cases.
Okay.
What you have.
So the first case that I have, it's not letting me control. Lucas, next slide, please. So a 60-year-old lady with bilateral foot deformities who presented to me initially about 3 years ago. Slightly asymmetrical deformities, both complicated by midfoot arthritis. Next slide, please. And these are the plain films. You can see that the left foot intermetatarsal angle around 16-70 degrees, whilst the right foot was around 20 to 21 degrees with more subluxation of the sesamoids. Sorry, I think we both clicked then. Yeah, I'm back in control. So right foot with the degree of arthrosis in the midfoot and the significant intermetatarsal angle, I felt was good candidate for a Lapidus and midfoot correction. Whilst the left side, I felt the pathology was slightly different. The TMT joint didn't appear to be as unstable. I thought that the second and third TMT arthritis was because of the biomechanical offload of the first ray rather than fundamental instability. So I know that the instability occurs, but I thought it was addressable through an osteotomy. So on the other side, we did the midfoot fusion and then combined it with an osteotomy distally. And final follow-up, which was only a couple of weeks ago. She's now at a year post the arthrodesis and about 6 months post the osteotomy. Interestingly, she feels that the osteotomy is her favorite side. She feels it feels as a more normal foot. And also interestingly, with regards to what we were just talking about, there has been a degree of recurrence on the sides of the Lapidus, and you can see that the intercuneiform space has started to open up on the side where I did not do a classical Lapidus, I just did a modified. And she did have a hook test at the time of surgery, which demonstrated no instability at the time of the operation.
So how can you have no instability during surgery and then you get it?
I think the forces change was the only way I can explain that. I think the assessment using a hook test is a fairly blunt instrument. And I think as you then are dealing with 60, 65-year-old tissues over the next year as they're mobilizing and weight bearing, there may become this gradual instability and gradual laxity that stretches out through the joint as the forces are transferred elsewhere in the foot, which is, again, one of those consequences that we know will happen with arthrodesis. You will create forces elsewhere that were not previously being exerted in that area.
Do you think the other side, you have also a TMT1 and 2 instability on the osteotomy side?
It's possible. At the time when I did that one, she hadn't opened up on the other side, and looking at intercuneiform instability is not something I routinely do as part of an osteotomy. She hasn't demonstrated she's opening up there at the moment, but she has more movement at the first TMT joint, which should hopefully protect the development of intercuneiform instability.
So Christian, what do you think by the case that we have here? You are happy with the correction?
My theory is, as Jim also said, that when you have a TMT2 and 3 arthritis, that you have an underlying TMT or instability of the first ray, which leads to an overload of the TMT2 and 3 joint, and therefore I always go for Lapidus arthrodesis in these cases. The relapse of the Listrong arthrodesis case is not completely clear to me. We just finished a study founded by the IBRA about intercuneiform instability and analyzing where it occurs, and you find that the intercuneiform ligaments are really very strong and really responsible for intercuneiform instability. So it's not the classical Lisfrong ligament, which we were looking at before. So I really do not completely understand what happened on the left X-ray. Perhaps we should have a look at the first X-rays again to see if there's.
Lucas, can you go back? Yeah.
One more.
Sorting. Yep. So that's the initial pre-op, post-op, and that's the presentation film.
Yeah. This is a classic case, no intercuneiform instability at the beginning, and then you see it later on. I think I would have gone for a complete Lisfrong arthrodesis with an intercuneiform screw.
So it's interesting. I'm just looking at the films. I've remembered part of the decision-making process for the left foot, which she had. She was starting to develop symptomatic osteoarthritis at the MTP joint on the left foot, which was part of the reason for moving away from the full first, second, third TMT joint on the left-hand side. The aim of preserving the TMT joint for a subsequent MTP joint arthrodesis if she needed it.
Yeah. But I think on the right side, you can see clear signs of a TMT1 and 2 instability with a severe deformity. Here I would go for a classic Lapidus arthrodesis and put a bone graft between the metatarsal 1 and 2 and fix it as Lapidus described it by intermatatarsal screw to neutralize the Lisfrong ligament instability.
Retrospectively, I wished I had.
Yeah. So do you have another case, Jim?
This is one of my patients. This is a 53-year-old female with a typical Hallux valgus pain, and okay, I got the control. What we did here was a TMT1 fusion. I think the horizontal correction is quite okay, but she was really painful. She really had pain on the first metatarsal, and what I wanted to show you in this case, you see here the problem with the vertical alignment due to the intermetatarsal screw, as you see here, because it does not only stabilize horizontal, but it also stabilizes vertical mobility, which leads in this case to an higher position of the second metatarsal. Can be a problem, and you have to be aware of this problem when you put in the screw, which was in this case easily solved by just removing the screw, and the patient was happy afterwards.
If you go back to this case, which is a really interesting case, you can see there is also a pathological DMMA angle. Do you think it's a real DMMA angle pathology, or it's still unrotated?
It's probably not completely corrected, yes. I agree with that. And you should have done a bit more Aiken also.
Yes, and here I have a question to both of you, because this is always the classic question. How often are you doing an Aiken? First, Carmichael, yeah.
80 to 90% of the time.
80 to 90%. So in which 10 to 20% you are not doing it?
It's usually based on table. And if having done my correction, I am worried that I will end up with either I'm delighted that without any form of a medial reef, I've got a perfect correction of the first ray, or if I'm worried that by adding a Aiken osteotomy, I will result in an overcorrection, I will not do an Aiken. But 80 to 90%, even if it's a small one, I will add an Aiken just to it seems to just give you that slight shift into a straight ray.
Okay, and you, Christian, how often?
Yeah, it's the same with me. I also do an osteotomy in about 80 to 90% of the cases. I think you often do not see the interphalangeus position on the preoperative X-rays. There are studies showing that it demasks during the operation when you derotate or when you correct the hallux, because it derotates then also a little bit with a classical technique, and then you see the interphalangeus position. So I also do an 80 to 90% achinostomy.
Okay. I had a few cases where I also had a situation or a feeling during the surgery, well, an ache is not needed, and then later on I hated myself.
Yeah.
Since then, I always do an aching. So when I get the question, how often are you doing an aching? I always say, I do it always. And since I'm doing always, I never hated myself since then. So, but this is a big issue also, and open question which is not solved. Yeah.
So this is a case just which I thought was interesting and fitted quite well with one of the ones that Christian showed as part of his talk. 60-year-old lady, unilateral deformity, unilateral symptoms, long history of pain, classic deformity, pain both over the medial eminence and underneath the second metatarsal head. Measuring the intermetatarsal angle from memory, I think it's around 16, 17 degrees. So again, as per my normal, corrected with a scarf and aching osteotomy. Now the reason I thought this, I was very pleased with it. She did at the time of surgery have a fairly significant portion of sesamoid osteoarthritis, and when we were getting towards the end of follow-up, she still had plantar pain. And so that's the reason for the sesamoid view. And I thought with the pictures that you showed earlier of the 16-year-old girl with a very malrotated metatarsal head, it was quite useful to show that you can have the appearance of quite significant subluxation of the sesamoids on an AP X-ray, get a correction, and the sesamoids can be made to sit nice and horizontal underneath the foot. And with her, we've concluded ultimately that her plantar pain was simply a function of the sesamoid osteoarthritis. And she's actually done very well. She hasn't, well, I say that, she hasn't represented to me with further complaints after discharge about 3 years ago.
Mm-hmm. Have you ever seen, both of you, an over-rotation of the sesamoids into over normal position?
Not yet. I'm thinking of a case that may still arise through follow-up, but not yet.
Yes, we did. We were quite eager at the beginning. I mean, you come from a technique with a wedge resection where you had to fight to get the good correction, and then you change to a rotational correction, which really allows you to overcorrect, and then you try to correct as much as possible. Then you can't end up with a varus deformity with a negative intermetatarsal angle. So when you do this rotational move, it's really, really powerful, and it's not that you do as much as possible, but you have to look that you do it right. So this is also a learning process you have when you change the technique. So yes, we had overcorrections at the beginning.
I completely agree with Christian. I am still learning the rotational correction part of the modified Lapidus with no wedge resection, and it can be challenging.
Okay, there is a last question for Christian, then we go for the take-home message. Christian, the question is, every time rotation deformity reduction is enough, do you cut wedges sometimes in your Lapidus? So are you really sure that with a reduction of the rotation, you can manage all the cases, or do you need to really cut also sometimes, or always?
This is something we were a bit did not focus on in this webinar. There are cases with dysplasia, with deformity of the metatarsal, but this is not the classical Hallux Valgus patient. This is not the classical patient which come with late 20s or in the 50s or the typical female, typical women which come with a developing hallux valgus. These are patients with juvenile hallux valgus. They can have deformity. All the others we can solve without a wedge resection with just derotation. The amount of rotation is for me not directly proportional to the intermetatarsal angle. So you can have patients with a large intermetatarsal angle where you derotate only a few degrees and derotate correct with only a few degrees of derotation, and you can have patients with a small intermetatarsal angle, but where you really see a big rotation, big change in the rotation of the metatarsal with the technique we use. And this is, for me, also the argument why I do the technique the way I do it, depending on the congruency of the MTP1 joint and not going to a defined angle correction.
Very good. So, do you want to read the take-home messages? Maybe Jim or Christian?
Okay, so fundamentally, I think the take-home messages that we've tried to engender is that both the scarf and Aiken and the Lapidus arthrodesis are completely acceptable options to perform in the cases where you have moderate to severe hallux valgus deformities. I think the overall correction and maintenance of correction is higher with a Lapidus arthrodesis, but there is some concerns that the foot mechanics may be less distorted with scarf and Aiken, which may have some potential functional outcome benefits to the patient. But there are, if you're going to undertake the osteotomy, you need to be aware of the radiological signs that indicate the instability that you're dealing with may be greater than you're expecting. And you need to be aware and appreciate those to try and minimize your risk of significant recurrence after a hallux valgus correction using an osteotomy.
Christian, your last comments?
Yeah, my last comment is that the Lapidus procedure is still underway, is still developing, and it needs good analysis of the pathology and a good understanding of the hallux valgus to do it right, and only then you get the really good results.
So I want to thank you, both of you. I think you did an excellent job. Jim and Christian, you showed us that the topic is very complex and it's not easy to choose the right solution. There is not a 100% solution for all the people. You have to adapt your technique to the case, evaluate very well the indication, perform a good surgery, do a good after treatment, and inform the patient that this is a very complex surgery and can have quite complications and recurrency rates. But I think you showed us that there is more or less an algorithm. I know you protected each of you, your osteotomy or Lapidus, but both of them have their part in the treatment of bunion surgery. The question is not whether, but the question is when you should use the one and the other to do a good job in this complex deformity of the foot. So in the name of the IBRA, International Bone Research Association, I thank you for being here. Thank you for your attention. Thank you to listen to us, to be active on the chat. And I wish you a good evening and good luck with bunion surgery. Bye-bye. Thank you.